between, everything belongs to you, sir.
Right. Why I got into it, I think, is what my talk will be about. It all got into it because we don't want any woman to die while giving life. I think that's the dictum by which I started my practice as ONG, and I'm still doing that. So we'll just share some of the statistics we have in Malaysia and see what we can go and learn from that. Thank you. Good morning. Thank you for having me here. Now, this is where I work. It's a red hospital, and if you look out of my labor room, you actually will see Singapore. So I always say this is the only labor room in the world that sees another country while you're delivering a baby. Now, these are some of the statistics of Malaysia that you'll see, and you can see that this is the latest statistics I have. The one for 2022 is being processed, so that will appear as 2023 statistics. And I want to let you all note on the birth rate. I think it's very minuscule compared to what you have here. But what is important to realize is that our birth rate is dropping. And in years to come, we may not have enough to replace even the existing numbers. And this is very alarming. And although thought we were doing well, but what we realized is that our birth rate has dropped significantly. And during the COVID years, we thought because of the multiple, with the MCO, that movement control orders and things like that, people will be spending time at home reproducing more, but actually no, they were reproducing less. So basically what is maternal death? This is just some of the definitions for a recap: direct, indirect, and fortuitous. And we must understand that maternal mortality is not a rate, it's a ratio, because the denominator and the numerator are two different parameters. And this is the Malaysian statistics from 1933 to 2020. Now, if you look in here, it looks like we have been doing well, and now we have plateaued. And these are some of the significant things that happened in Malaysia. And you'll see the most important intervention was the introduction of the nursing services, particularly midwifery services. And we obstetricians actually came in late, jumped on the bandwagon and trying to take the good name. Actually, it's the midwives who did most of the work. And in 1991 was when we started the confidential inquiry. We were the third country in the world to do so. And we have been doing this, and this is how we have been performing in the last 10 years. Now, if you look into the maternal mortality ratio, we have been hovering around the 20s. We are struggling to bring it down to less than 20, and there are a lot of reasons for that. And a big bumper was when COVID came in, and you can see how it has impacted us. And if you look into the statistics of COVID maternal deaths from the time it came, January 2021 to June 2022, we had 197 maternal deaths attributed to COVID. And out of that, in 2021 alone, there was 193. 94% were unvaccinated. And the MMR in 2021 from 23 came up to 68.2. So you can see the impact of COVID that has disrupted our targets. Now, the CMD has been on for a while. We have many reports. Recent report, I just sent a copy to Dr. Piley about a week ago. It's now online, you can see that. Now, what I want to show you here is not to look at the numbers, but if you have a good audit, the data that you can get is fantastic. And with that data, you can do a lot. So I'm going to run through this. So basically, our data collection will tell us indirect, direct, and fortuitous. It will tell us by the ethnicity. And in Malaysia, we Indians are not doing that great. In fact, we are the worst performing community among all. And the Chinese are doing very well. The Malays are in between. And we also look in terms of where the maternal mortality occurred. Whether was it in the government, private, or at home. And you'll find the highest is at home. And unlike here, the majority, 85% live in government facility, 10 to 12% in the private sector. It's a complete reverse of what's happening here. This is by the status of the thing. And when we looked at this data, it was very interesting. Because we have a very comprehensive antenatal care which is free, we manage them very well. Intrapartum, facility-based is the majority, we do them well. But when we send them back to the community is when we realize we are losing a lot. Because at 6 weeks puerperium, we tend to have neglected our care. So we have revised our postnatal care, and we are coming up with a new strategy. Okay. Now the common causes, of course, the traditional cause has all been postpartum hemorrhage. You will never know what it is. But now the newest cause for us is actually medical disorders, particularly heart disease. And whenever we have statistics of our maternal death, We will divide them into preventable and non-preventable to see where we can do better. And when we look into the preventable cause, this is what we found. So this is what the whole purpose of the audit is, to see where you can intervene. And this is when we look into the clinical factors. And the thing that worries me most is, if you look, failure to appreciate, failure to diagnose, failure to communicate. That means you and I are making these mistakes. And you will never know this if you don't do an audit. We all think we are doing fantastic, but failure to diagnose is really, really worrying. And then when you look at non-clinical factors, we find a lot of things. And one of the things that we found was, we had a maternal death because the ambulance ran short of petrol while on a transfer. Now we have a new policy. Every ambulance in the facility must have at least half a tank of petrol. If not, the hospital director will be taken to task. Now this is where we have our biggest hurdle. Patients, very difficult. And they control and they do these things to what they want to, and it becomes very difficult for us to intervene. Now, what we see is very small, what is behind is very big. So we migrated to a maternal death and surveillance response. We got our Director General into it, we got our Minister into it, so it became a post-cabinet decision. So every maternal death is informed to the highest authority, and every post-cabinet meeting it will be discussed. And why? These are all the reasons I think we will know. But the biggest problem is, having all this is not the issue. You must look and see where the reason is. It'll be staring at you, but we may just walk by it. So basically it's a process of identifying it, investigating, and giving feedback. No feedback means you're not going to improve. And this is what we looked at it, things that you can change at your level and things that you have to change at a higher level. And this is the whole process. So what did we do? So this is some of the achievements that we have established. It did not become a problem of the obstetricians alone. We have encompassed as many people as we can to share the load, on in a very selfish way to share the blame. We have come up with many training manuals, and these training manuals have actually brought down the incidence of these events causing maternal death. We have concentrated a lot on midwifery. Midwifery is a big thing in Malaysia. We made the program from a certificate now to an advanced diploma. Every midwife has to go to the obstetric life-saving skills course before they can function. They have to go to the neonatal resuscitation program as well as basic life support. If they don't do this, they will not qualify as a midwife. We have brought in a lot of consensus statement in government policies. We have now consensus on use of misoprostol, placenta accreta. Contraception has been made very available. In fact, contraception available almost free. We have come up with very progressive termination guidelines. We are the first Muslim majority country that has come up with a termination of pregnancy guidelines that we can be shared online. We downgraded drugs. We allowed nurses now to handle all these drugs. Magnesium sulfate, which is a list A drug, is now list C. So if there's an eclampsia in the periphery at home, the midwife can start the loading dose at home. So by the time she reaches the hospital, the medicine is already working. Heparin is also now allowed by nurses, even dexamethasone, and they are all trained. Post-mortem now has become mandatory. Very difficult to get this through, but we have managed to get this through. And of course, we have started the obstetric registry. I started this in 2009. It's still ongoing. You can access it online. It's the largest living obstetric registry with a database of more than 1.4 million patient data. So we use that to influence our policies. And these are the reports. And whenever there's a sentinel maternal death, we come up with case illustrations, and this is circulated throughout the fraternity and to other stakeholders as well. And this is an ongoing thing. And more recently, we have started a near-miss audit, because sometimes we want to see what is it that we did wrong, but the patient still survived. So these are some of the interventions that we have done to learn and to continue to learn. So sometimes what we need to do is look at the problem hard enough, the answer will come to you. And we of course publish some, and we have to work as a team. Thank you very much.
Thank you very much, sir, for that presentation. But then there should be some things that how we would like to ask you on behalf of everyone is, what are the lessons that you derive from this confidential review, and how much of state policy changes as a result of this sort of thing? This is very important.
I think the lesson we learned is that before we can talk to anybody about any change, you need to have data. You need to tell them what is it that is going wrong. You need to tell them what needs to be done to make it right. Once you do that, then people listen to you. So this is how we managed to get the attention of the politicians. And with a political will, it is very good. And in my country, it was a very strange situation at the time when we managed to get most things done. I am Indian. The minister at that time was a Chinese, and the majority of the maternal death was among the Malays. So it was very easy to get an integration among all three races, and we managed to get through. So the important thing is that with all this new program come, that's how we managed to change the midwifery program from just a simple certificate course to an advanced diploma. Then we also managed to get more money to buy contraception, which initially had to be at the pocket from the patient, but now it is given almost free. Antenatal care is 100% free. Postnatal care is 100% free. We have postnatal care where now the midwives actually go home on day 1, day 3, day 5, day 7, day 9, day 14, and day 20. They actually go home to the home of the mother to look at her and her baby. So these are things that we have managed to do because we have got the data that comes from our CMD to make the intervention possible.
Another question, though I know, sir, it will be difficult to answer that one, is from the slides that you showed, we saw a plateauing out of the maternal mortality ratio. Now, from a common obstetrician's perspective, we see that when we have accidents related to, an unfortunate maternal death, you have to answer the press. There's this question that, why can't you just see that it's not there? So I know that's impossible, but then being in a position that how would you deal with that particular question? And with respect to your slides, my question to you would be that where do you plan to go ahead from here, given that your ratios have plateaued?
I think from my slides you'd have seen that over the years we are getting more and more people on board to share the burden on looking after them. And one of the first things we did was to get the media onto our side so that they do not start publicizing and sensationalizing the unexpected event of a maternal death. They will not unnecessarily publish wrong things. It's at every level of the media. They are very responsible. And they only will be able to say what has come out from the post-cabinet release by the Minister of Health. So in that way, a lot of events are controlled, and we use the media a lot to get messages across, to say that the services are free, you can come in at this time, if you can't come, let us know, we will come to you. So that's one. The second thing is, we found that if you look into my data, you will find that the biggest problem we have is actually patient factor. Now, patient factor is something that you cannot do it at a ministerial level. You have to go down to the ground. And this is where we are involving now the Women's Ministry, the Education Ministry, and even the Home Ministry to get us to go right down to the ground level to see what is the issue. Many a time we found the issue is actually financial. They don't have money to come. So we say, now you don't worry, we will come to you. So the change should happen, but we expect to see the results maybe in the next 5 to 10 years, not immediately.
Thank you very much, sir. I will so you can please have your seat. Just with sir on stage, I would just like sir to have just one word regarding the things before we go ahead to Mandakini madam and this thing.
You have been echoing the same sentiments that we have been facing and feeling. I just wanted to ask you, are you of late bothered with this drain of the nurses that we are facing in India, particularly in Kerala? We don't get trained nurses to stay more than a few months. Do you have that issue there also?
For us, whenever a nurse comes to do a midwifery course, she's bonded to serve the government for 3 years.
Bonded, is it?
Yeah, because they get paid and they also get trained. So they are bonded for 3 years. So, and we sort of managed to replace that.
Okay, thank you. I see that he has about 4.3 lakhs births in the whole country. Am I right? We also have about 4.3 lakhs of births in Kerala. You have how many deaths, maternal deaths? Rough number? MMR you are talking about. MMR 27, 23, 24, something like that. The COVID, you lost about 195, 93 women. We lost 95 women due to COVID in our state. Many things are similar, parallel, and you are worried about your birth rate, which is now coming down to 1.7. Yeah, 1.7. Ours is 1.7 for the last 15 years. So we are the below replaceable rate for the last so many years. You know, replaceable rate is 2.1 and we are 1.7. I am really concerned that Kerala is going to be replaced by people who are migrating to Kerala rather than the real Keralites. That is the worry that we have for the last few years. Anyway, we cannot help it. Coming back to
So
what
back
to do
to
in
our
Maharashtra.
things, we had Ravichandran sir narrate the Malaysian experience. Everybody knows Kerala is on top of the ladder as far as MMR reduction, but then we have a second state, Maharashtra, which is second, so giving and Mandakini madam was the deputy director in charge of reproductive health in the state of Maharashtra. So she would like to share a few experiences about how Maharashtra has managed to reduce its MMR.
So, good morning, sir. Dr. Bailey and everyone for, giving me the chance to present the Maharashtra data. So, I'm going to give you an overview how the Maharashtra has fared in lowering the maternal mortality. Maharashtra experience for reducing the maternal mortality. This famous statement we know, I'm not going to repeat, but very important is that we have huge decline in the maternal mortality, and Kerala we think is our big brother, and we are following Kerala at every step in the maternal health. But demographically you can see there are many states which have yet to reduce it and achieve the SDG goal, but 8 states have already done. Like significant decline in the maternal ratio, say from 130 to 97 per lakh has already been achieved, and there are 8 states which have already achieved, but there are many states which have. So this SDG goal we have already done, but here Maharashtra ranks second in the country to efforts to bring down the maternal mortality rate. And what actually has led to this reduction, I am going to just describe it, that we have come from 68 to 33 is the recent figures. And as Dr. Venugopal has mentioned, I take, I really honor for me to be in the helm of affairs as a deputy director in charge for the reproductive health, and a lot of policies has been made in those periods. So now look at the data. From 13-15 we had 68 per 1 lakh live birth. We had 14 to 16 we came to 61. After that 55 and now 33, and this already SDG goal has made a huge reduction in the maternal mortality. So what actually were the reasons to reduce? So first and foremost, I think, I don't know, there were only 3 states in India where this World Bank project was taken. That was the Maharashtra Health Development Project. And what does it contain? It had identified the loopholes in the system and worked on it, like strengthening the FRUs and the sub-district hospital, because we have a robust structure, health infrastructure, where we needed the improvement. So we have constructed labor rooms, we have constructed neonatal wards, we have constructed OTs, we have supplied the ambulances, we have upgraded the hospital from 30 to 50 beds and 50 to 100, upgrading the skills. All training, all kinds of trainings were given, and I think many of the faculties, Dr. Paili and many, Nozer is here, many of you were invited as faculty for this. Then upgrading the skills and the human resources was very, very important. Also, sir has mentioned about the nurses. So we had lot of nurses training, and we have increased the capacity by the Indian Nursing Council in the state nursing colleges also. You can see here a beautiful, sub-district hospital which has been upgraded in my time when I was in charge for the World Bank also. Now the infrastructures, we have a robust infrastructure, so many, I'm not going to repeat the figures you can see here, But surprisingly, you can see in Maharashtra, Pune is the most equipped city in India, with 3.5 hospital bed per 1,000. And it was a very surprising fact that Pune is leading in Maharashtra as far as the infrastructure facilities are concerned. Also, we have done the 248 first referral unit, which we are being used as a normal delivery as well as for the C-section. 3 minutes, yeah.
No, 1 more minute, ma'am. 1 more
Yeah.
minute.
So these are there. And then we improved in the quality of healthcare, equity healthcare, financing. Lot of finances were diverted for the maternal health. And most importantly, doctor from the Maharashtra, I can see here that OBGYN were deputed from the private practitioner, I can say, deputed from the district to the FRU. And they were given a handsome amount, say from 5,000 to 10,000 rupees for doing the cesarean section. Anesthesia, pediatrician, they were earning quite a lot, and that made things very easy for the state, because we were not posting or deputing, but we are taking the services of the private practitioners from the nearby districts or from the metros. And training life-saving skills of anesthesia. MBBS were given the life-saving skill 3 months in KM hospital and many hospitals, and they could give the anesthesia to the cesarean section, and that solved a lot of problem of our anesthetists in the need of our EMOC, BMOC, IMNCI, training of staff, and also MTP training. Lot of people, medical officers we trained, private practitioners we trained. And here you can see the schemes. All the central government schemes, Maharashtra schemes are doing extremely well. I will not repeat the figures, but you can see it is doing extremely well as far as all the schemes are concerned. And one scheme which I want to mention here about the Now Jivan Sanjeevani Yojana, exclusive for the tribal area, that is 16 district where 400 rupees is paid to the, for the loss of wages of the tribal women. Then there are, human development program, and all these figures are very, very impressive figures in the Maharashtra. Anemia Mukta Bharat. And last but not the least is now the new WHO guidelines have come, which are very strictly we are following. You all know about the guidelines. I don't want to repeat here, but these all things led to the, and recommendation for the respectful maternity care, which we already have. At about 80% of the labor room, we are already having this. So our nation's progress can be judged by the health of the women. Thank you very much for that patient hearing.
Thank you very much, madam. I know the time was less, but sir, just for your last words to wind up this.
No, thank you very much, Mandakini. And I know from the day we started to see you in Mumbai, you have been always dedicated to this aspect. And so grateful that you came over to share your views and experience with us. Thank you all once again. Bye.
Thanking the whole team, Dr. Venugopal, Dr. Mandakini madam, and Ravichandran sir for sharing the experience. We are straight away moving to the discussion session. Actually, we have 2 discussion sessions. So, Dr. Pramila